At the time this paper was written and we were looking at this initiative or agenda, how did it differ from perhaps other proposals or at least other aspects of the healthcare reform discussion at the time? I know the pandemic has forced a lot of change in that conversation and even in policy. But when we were looking at this paper, what were some of the key differences between what we were proposing versus what might have been in the conversation in other parts of the country or other aspects of this issue?
I think looking back on it, from the perspective of now, when I went back and reread it, um, I think I was not surprised because I certainly read it a bunch of times as we were working on it. But I think the pandemic and everything that has happened since in the political environment makes it an even better paper. Because when the idea originally came to do that paper, and we did a bunch of papers as part of that initiative, there was always this tension between making a really comprehensive, new, bold, start everything from scratch idea on the one hand, or trying to find ways to tinker and improve things on the other. And a lot of times, that new bold thing is what people push for and you kind of look for. Um, but this paper instead, I think, took a very methodical way of taking the reader a policy, someone interested in the policy, through all of the different parts of the healthcare system and the ways that those different parts can be improved to where in the end, the sum of those parts winds up being a really big improvement in what we could expect from our healthcare system. Um, and so that's what this paper did. And I think at the time, during the primaries in the Democratic Party, there obviously was a great debate about this, whether um, do a completely new thing or whether you work at it incrementally. And in that party, the incremental kind of plans also won the day. And I think the pandemic also shows how um, the idea in this paper of getting to these changes, making the system more efficient, attacking each area of market failure, doing all that gives us the quickest way to having a better healthcare system. And I think the pandemic shows how important that is. Because if you spend a lot of time arguing about something that may not happen or that is completely disruptive, you have an opportunity cost of not having a better system in place as soon as possible. And I think we kind of all wish that right now we had a better system already in place. And so I think it's imperative to get that better system as quickly as we can. And I think this paper really shows us a lot of areas where we can get there.
We talked a little bit about the employer provided aspect of our system, and you're talking about competition. So I'm actually curious, starting with you, Joe, and Josh, certainly jump in. What's quote unquote shoppable in our healthcare system? And will patients actually parlay procedures while looking for more affordable alternatives? Like I get the concept of competition and I get the idea of transparency, but will like there's sort of a psychological feature here. Will people actually shop around for more affordable healthcare?
Yeah, that's a great question. Shoppable. So clearly, it has to be something that doesn't scare the patient. If this is life or death, it's not shoppable. If you have been in a car accident and you're unconscious, it's not shoppable. They will be dragging you off to the emergency room. What is shoppable are things that are they're ideally they're necessary services, but you have time and ability to, at least in concept, to see whether there is a lower cost provider. Again, ideally with some information about the quality of care that's provided. The most obvious example would be imaging. Um, where do I get my MRI? And there are several places that you could go. The absolute worst place from a resource standpoint is going to the MRI at the hospital. Uh, uh, they have the highest charges. because they're not only paying for the time of the technician and the electricity to run the machine and the, a little bit of the capital cost of buying the machine, but you're also buying a major chunk of a very nice looking building. The alternative is a standalone imaging center, which is often much cheaper. But again, it depends, at least from the patient's perspective, on is that imaging center in the network or not. Even in a simple case like that, where to some extent an MRI is an MRI is an MRI, there's still a lot of questions that you really want to be able to answer, and it's very hard to get those answers. So oftentimes it's the easy way out. It's either the MRI down the hall, or if you actually are concerned about cost, you might ask as you go down the hall, are you in my network? And ideally the answer is yes, but that doesn't necessarily mean it's the lowest cost alternative.
I think one of the things that the paper did well, and that I know we talked about a lot while we were um, writing the paper, was that you need to start getting doctors involved in the shoppable, that we can't just rely on patients to look in some directory, which often is very difficult to figure out and isn't up to date anyway. And that you really have to have doctors, when they're referring patients to those places, to let that choice happen with them there. So they can see on their computer screens for this specific patient which place is the best place to get an MRI. And let the patient and the doctor right then make that decision together. So getting the doctor more involved in helping patients make those choices as quickly as possible is really the way to take advantage of that. And I know that Joe and Alice talked a lot about that when they were writing the paper.
Let me just add, that's exactly right. And you explained it extremely well, Josh. I appreciate that. This concept ultimately should be applicable to other non-emergency services that are more complicated. The information is there. The computing power is almost there. The connectivity to connect the dots of where the information is to the people who need it most, which, as Josh says, is basically your physician and you. That we can connect those dots eventually. Technology is a great thing if we're willing to do it. Part of the problem is that the insurer wants to keep you kind of in line with its best financial interests, which may not be in your financial interests and may not be in the physician's interests either. So it's a very, very complicated situation. That's why we talk about shoppable services in this kind of simple way, but there is a vision for the future that I think is at least technically feasible. The question is, can we make a business out of it?
We talked about the employer provided aspect of our system and alluded to the tax benefits associated with it, making it difficult to make changes in that regard. So my question is there a way to keep a largely private health insurance and healthcare system, but decouple it from the employer provided aspect of the system beyond just changing the tax incentives? Like, are there actual policy changes that go beyond the tax code that would help make a transition there and make it even feasible?
In a way, this is what the originators of the Affordable Care Act thought they were starting us on a path towards, is that if you create this alternate system and have proof of concept that you give people subsidies through the tax code that they use themselves to purchase insurance, um, and they get used to that, and you have marketplaces in every state that kind of work well, that give good information, that highlight the competition on a bunch of different areas between insurance plans. um, it could become a situation where individuals take money with them and pick their health insurance in a kind of simple Amazon.com way. Um, and one of the logic behind the Cadillac tax was to slowly erode the employer provided tax deduction, um, use that money to build up that exchange, and maybe somewhere down the line have people be free from employer provided health insurance and do it on their own. I think that logic um, is still ultimately the right one. I think everyone acknowledges we would be better off uh, in that situation, regardless of where we are now. It is just that the transition is very expensive. It involves a lot of change. There is a huge amount of status quo bias among voters and politicians, and that transition is the most difficult piece. And I'm not sure we're any closer today with that wholesale transition than we were 10 years ago when the ACA started.
Yeah, I generally agree with Josh on this, but there's also the risk of losing something here, and frankly, I don't can't see my way clearly through this, and it really goes back to something Josh said earlier. Um, Large employers have used a form of reference pricing to lower their costs. And why were they interested in lowering their costs? Well, because they are so-called self-insured. They're paying the full boat for coverage for their employees. And in certain cases, for example, Boeing had a large number of cases of people with lower back pain. And they were getting back surgery, and the back surgery did several things. A, it generally did not help the patient because it really wasn't called for. B, it cost an enormous amount of money, and it took an employee who was being paid off the line for 6 months or more. And so what they did was they entered into a contract with Cleveland Clinic, and basically they said, we will cover all your costs. You can go to Cleveland Clinic, and they will give you a workup, and then they will recommend what they believe is the best treatment. And if it's back surgery, they'll do it. And or you could go back to back home, and you could pay more for that back surgery, or you could take the advice of the people at Cleveland Clinic. And by and large, the Cleveland Clinic advice was, you don't need back surgery, and we will supervise remotely your physical therapy, which is what you really need. Uh, there is an element of information there. There's an element of trust, but critically, uh, there is an entity that has a strong interest in lowering the cost. When you go to insurance companies, it's not entirely clear that they have a strong interest in the lowering costs. So you have to look further to ask, what are the other financial arrangements that would make the exchange system really promote cost awareness on everybody's part, including the insurer.